Okay, so good morning, everybody, and welcome to the AOMA 2023 Summit. It's really exciting that the day's arrived and that we're going to have this full day session talking about ocular melanoma today. So on behalf of Anthony Joshua and the organising committee, I'd like to start with an acknowledgement of country. Nina Mani, which is the Ghana welcome. On behalf of Masked Trials and the speakers here today, we acknowledge the traditional custodians of the land on which we meet. We pay our respects to elders past and present and recognise their enduring contribution to the culture and spirit of the land. So now, Anthony, I'd like to hand over to you to recognise our sponsors.
Thank you very much, Rachel. So we certainly have to extend significant thanks to the sponsors of this event who have made it possible to carry out this on a global scale and really help patients not only in Australia but also around the world who have ocular melanoma and raise awareness. So those sponsors, the platinum sponsors, I do have to call out specifically for their significant contribution. That's Medison and Idea Pharmaceuticals, and also our silver sponsors, the Safe Sight Institute at the University of Sydney, as well as Eckert and Ziegler. So thanks very much to those 4 organisations for really contributing to the mission and the values of AOMA and helping patients around the world who have ocular melanoma.
No, I agree. Thank you very much. So we're going to now start with our keynote talk this morning. So uveal melanoma, where we are and where we are going. We have Associate Professor Marlana Orloff, who's going to give the keynote talk this morning. And at the end of the session, we've got some time for a question and answer session. If people would like to put their questions in the question and answer box there, we can ask Marlana some questions. So Associate Professor Marlana Orloff is a medical oncologist at the Thomas Jefferson University and Sidney Kimmel Cancer Center in Philadelphia, Pennsylvania. Her focus is on rare melanoma subtypes, including mucosal, conjunctival, and uveal melanoma. Her research is centered on investigating the epidemiology of rare melanoma subtypes and the discovery of novel therapies. She works closely with a multidisciplinary team involving ophthalmology, interventional radiology, radiation oncology, and medical oncology that treats patients with uveal melanoma. So very looking forward to hearing Marlana talk today. Thank you.
Okay, let me just share my screen here. Okay. How does this look? Thumbs up? Good. Okay. All right. Well, I just want to extend a huge thank you to the organizers of this meeting and to AOMA for having me. You know, it is about 7 p.m. East Coast time in the US. I know it is already Saturday morning where many of you may be, but wherever you are, whatever time it is, and certainly for those of you who end up watching the recording of this, I hope this talk really kind of sets the stage and also really gets everyone kind of excited about where really the field is going. So as you've heard, the title of my talk is Uveal Melanoma, where we are and where we are going. And I know there are a number of great talks throughout the rest of the day. So hopefully this sets the stage. Here's my disclosures. Okay, so where we are, you know, and I know that the majority of this talk certainly is set in regards to me being in the US, and maybe where we are and even certain parts of this timeline may not be applicable for everyone globally, but I think generally speaking, we're kind of all on the same page. Certainly all on the same page in that we've witnessed over the last decade now a number of treatments approved in cutaneous melanoma, whether be immunotherapy or targeted therapy in both the metastatic setting, adjuvant setting, and really now very much in the neoadjuvant setting. It wasn't until 2022 that we had our first FDA approval specifically for a drug in uveal melanoma, that being Tebentafusp. On here, just to remember, there are other melanoma rare subtypes, certainly mucosal and actually conjunctival, which I should have a color-coded box as well, does not yet have a specific approval for their rare type. So uveal has paved the way in regards to an approval for a rare subtype, but as you can see, we have some catching up to do. So currently, in the US and in our practice, we see quite a bit of uveal melanoma. We have really started to stratify our patients, certainly at the time of first metastatic diagnosis, based on HLA type. So patients who are HLA-A201 have the ability to receive Tebentafusp, but there are other treatments that we can offer those patients, including clinical trial, local regional therapy, and then the immune checkpoint inhibitors. For our HLA-A201 negative patients, the preference is clinical trial. We do have local regional therapies and immune checkpoint inhibition also as an option. I know there is a talk later today on local regional therapies. I will be going through a number of ones that we do primarily as standard of care, but really in the category of local regional therapies, that includes everything from surgery to ablation to radiation to embolization procedures, and also to things like IHP and PHP, which are intermittently an option kind of as standard of care or on clinical trial. So just to remind everyone, the immune checkpoint inhibitors have been tested in uveal melanoma, many case series, some prospective, some retrospective, and at least in the US, the best experience has come out of MD Anderson, where 35 patients who received ipi-nivo at any line had an overall response rate of 18%. However, when you look at a number of their series, the response rate is not nearly as high, and certainly not nearly as high as we see in cutaneous melanoma. They're in the gray for comparison. And the concern is that without the response rate, but these patients still get all of the toxicity. So clearly there is a real high unmet need to improve on this. There has been another checkpoint approved, at least in the US, of nivolumab and relatlimab. There has been a trial ongoing. Some preliminary data was presented at a previous scientific meeting. I think the verdict with that combination is probably it's going to sit somewhere similar to ipi-nivo, but with a better side effect profile. But again, still, so these are options for patients, but certainly we can do better. So as many of you may know, the drug that we now have approved showed an overall survival benefit when compared to investigator's choice, many of which those patients did receive an immune checkpoint inhibitor. Just a little bit about the mechanism of action for those of you who may not be as familiar. It's what's called an ImmTAC, which is essentially a type of T-cell redirector that really engages any T-cell. Does not have to be a cancer-specific T-cell, but really any T-cell, and through HLA presentation of GP100 on the cancer cell, really forms a synapse, leading to hopefully cancer death. So that's the mechanism of action of Tebentafusp. Again, it's HLA restricted, and the target is GP100. So the primary endpoint, one of the primary endpoints of this trial was overall survival. And here you can see that Tebentafusp outperformed the control, where again, investigators had the choice of single agent immune checkpoint or dacarbazine. most of which patients received checkpoint, and the median overall survival being 21 months versus 16, with a hazard ratio of 0.51. So this was really what got the drug over the finish line. And we had glimpses of this, in the original cohort of patients that was treated, many of which, so this in the registration trial, these were patients who were treatment naive, but in the first cohort of patients that read out on Tebentafusp, a lot of patients had multiple prior lines of therapy, some 3, 4, 5 prior lines of therapy. And in that cohort of patients, there was a 1-year OS of 70%, which had not previously been seen in any systemic therapy for uveal melanoma. So we had an early clue in the early phase 1s, but certainly it was the registrational randomized trial that proved such. And interestingly, the response rates were not significant. So response rate really only of about 9%, one complete response. This did outperform investigator choice, but, one with that, such an improvement in overall survival, one may have expected a bit of a better overall response rate, but a decent amount of stable disease and a disease control. Similar to, what we've learned over the last decade in other immunotherapies, it may be such that overall response rate, or certainly radiographic response by RECIST, doesn't tell the whole story. We've certainly shown this in a cohort of long-term survivors. So this is a cohort of patients that we presented on for the first time about a year ago at ISOO, where we had been treating patients for quite a long time over a number of the clinical trials before the approval. And in about a third of patients with more than 3 years follow-up, we had actually shown about or over 3-year survival following any exposure to Tebi. So these are patients that could have been on Tebi for a short period of time, or could have been on Tebi for a long period of time. But as you'll see by the swimmer's plot, a good portion of them, like I said, about a third or so of them have lived 3 years following any exposure. We have 2 patients who actually continue on therapy for now 51 and 80 months ongoing. Both of these patients had had prior liver-directed treatment and had progressed. The median OS is really not reached, though currently approaching about 68 months from initial metastatic disease, and about 44 months post-Tebi, but median really not reached. And this is really far exceeding what is typical of patients with metastatic uveal melanoma. And the interesting thing is, prolonged survival in the subset of patients, really despite 85% of them having progressed. So again, this speaks to that overall survival that was seen in the pivotal trial that didn't necessarily correlate with the response rate. Most of the patients were treated beyond progression. I think we are now, with number of patients having received Tebentafusp and kind of the data being amassed, I think certainly a multi-center analysis of both long-term and short-term survivors is warranted to kind of better understand these patients and these groups. And I think, prior and subsequent therapies will also help inform combination and sequence strategies. Certainly, once there's other treatments we have available. So as I mentioned, this is just our swimmer's plot, and I actually realized that I don't think this is the most updated one, but I do want to call attention to a number of patients who are still alive and off treatment at the time that we looked at this. Many patients who progressed actually fairly early on in their course and either immediately came off or went on to another therapy, but then went on to live quite a long time. And then patient 12, who actually is still on therapy, and this is the one that I didn't shift to the right, it actually progressed at about a year, but then has been treated beyond progression and has responded and still remains on treatment. So I will pivot from, what I'll call standard of care immunotherapy to local regional therapy. And I know that these treatments are not necessarily standard of care options globally, but we do have them available in the US. And I know there is a talk later on local regional therapy. So hopefully I will just kind of briefly mention, and then they will be discussed, or some will be discussed later on today. So the approaches that we have available to us, at least in the US, are something called immunoembolization, radioembolization, chemoembolization, ablation, external radiation, and surgery. Immunoembolization in many ways is a kind of homegrown technique that was started at Thomas Jefferson University, my home institution, by my colleague and mentor Takami Sato and team. And so, the rationale for embolization was not new. We know that the liver gets dual blood supply. We know we can take advantage of the fact that the arteries primarily get their blood supply from the hepatic artery. And then the hope was that with destruction by embolization, this may increase antigen presentation, and then locally infuse GM-CSF and IL-2 to really help improve antigen presentation and essentially create an in situ tumor vaccine. The substance is mixed in a ethiodized oil called lepiodol, and then there's a temporary embolization agent. So it's not permanent embolization; it's a temporary gel foam sponge that's then infused to basically near stasis. And this is done with a contrast medium typically, so that our interventional radiologists can see things in real time. So on the right is a angiogram of a patient receiving immunoembolization. And for those of you who may not look at angiograms a lot, what you can see is the at the end of the kind of hair-like arteries, you can kind of see two large, balls, and those are tumors. And 2 months later, those tumors were really very much dead and no longer receiving much of a blood supply. And there was a radiographic correlation to that improvement. So this has been a treatment that we've offered patients for quite a while at Jefferson. There was a prospective randomized trial and then a subsequent retrospective study over a number of years. Median OS was about 16 months, and actually an OS 1 year of 70%, which is actually fairly similar to what the initial Tebentafusp group was showing. But you can see there was a drop off at 2 years and certainly at 3 years, showing that, while this treatment can be very effective up front for disease control initially, there certainly was still a need, certainly back in 2014, for subsequent therapies to continue to keep patients alive. There was kind of a separation, almost similar to again, that TEBI group, in that there's, we kind of separated, there's patients who really could live a very long time. And there's patients who, don't necessarily respond and succumb to the disease much sooner. And you can see with the median OS and kind of the responders, it could be as high as 52 months. And really what this fell out to look like is about 15% of patients could have an exceptional response to immunoembolization, sometimes only needing, a handful or dozen or so of immunoembolizations over a number of years to control their disease. And that's all they really need. And here is an example of that. A patient who was treated, red arrow pointing at the tumor back in 2010, has had intermittent immunoembolizations. And really, this is where the disease is now in 2022. Another treatment option for our patients is radioembolization. We tend to use Cerspheres, which is yttrium-90. The other option is something called TheraSpheres. The dose is calculated based on tumor volume primarily. There have been a number of studies looking at this. Radioembolization is something that's much more available because it's used in other cancer types. Disease control rate can be shown to be as high as 50 and 77%. We did a prospective randomized trial at Jefferson, where we actually randomized patients to receive either IE or so immunoembolization or radioembolization first, with an option to actually cross over to either at progression. And so here you can see the patients who were in group A had a clinical benefit rate of 87, and this actually was a little less than in group B, suggesting that possibly the sequence of the IE first, or I'm sorry, that the group A is treatment naive patients, so no prior therapy, whereas group B were patients who had IE first and then radioembolization. So this showing that the group that actually got radioembolization may do a bit better from an initial clinical benefit rate, but then you can see that overall survival was quite similar. Another option we have for our patients is chemoembolization, and historically this is a treatment that we would offer patients with larger tumor volume. Unfortunately, despite risk prognostication and trying to get patients on MRI surveillance, we still do have patients who present with greater than 50% of their liver replaced by tumor, and we know that these patients can go downhill pretty quick. So this was a study looking at such patients, and they received BCNU as the drug as part of chemoembolization. And actually, we showed a disease control rate of about 72% with a median survival of 7 months. Again, this was a number of years ago. Certainly, with patients who might have had that initial disease control, there wasn't much option for them, certainly in regards to systemic therapy following. But here you can see 1 year OS. We do have a trial ongoing now with chemoembolization, actually treating patients with smaller disease. And then also we'll be looking to see if using chemoembolization as an initial therapy for patients with very bulky tumors, kind of controlling the liver and then moving them on to, one of the various systemic therapies that we now have available, may be beneficial to kind of draw out that disease control rate and ultimately improve overall survival. The other local regional approach I want to mention is ablation, because I do think it has played a role in a lot of our patients' treatment plans, and we are using it, I would say, quite a bit more these days. So, historically, we've really reserved it for patients who present with solitary disease. We tended to have a rule of, patients kind of needing to be a number of years out from their primary, only because we've found that, patients who present with a solitary lesion, even if, say, they're just 6 months, a year or so out from their primary eye, it's normally kind of the tip of the iceberg, and on a subsequent scan, other lesions pop up. But some of our patients who present, say, 3 years out, you can get serial scans and they may still just have one lesion, and for which ablation could be a good treatment option. So there have been a number of studies looking at this as well, both elsewhere, and we also did looked at patients at our own institution. And these were patients not just with, oligometastatic or solitary lesions, but what we call a rogue lesion. So patients who may be on another treatment, whether it be another type of local regional treatment, like embolization, or a patient who's on systemic therapy. And, everything but one tumor seems to be growing. We go in and if it's accessible, we will ablate it. And this has really seemed to improve overall survival and really time that patients can stay on whatever that other therapy is, as long as everything else seems to be controlled. And here on the right is just an example of a patient who had a solitary lesion that was ablated. And then a year later, on certain series on the MRI, you can almost kind of see the cavitary kind of hole that it puts in the liver, where it could be confused as being larger, but when in fact you look at the diffusion weighted imaging, and that's really just a crater that was made by ablation, and there's no viable tumor. So again, that was just a snapshot of, what we have going on right now, what patients have available to them. But what I think is really exciting is where we are going. There are lots of approaches in development that spans immunotherapies, targeted therapies, local regional therapies, combination strategies, as well as adjuvant and neoadjuvant approaches, which we've certainly been in need of for the last number of decades, but we had always been kind of waiting for having an effective therapy in the metastatic setting to really design a a good adjuvant and neoadjuvant trial. So what I did here was really just kind of just to show the breadth of the trials that are open in uveal melanoma. I always say when I first started doing these talks, I could really fit the number of trials that are specific to uveal on half of a page, but these are all really trials that are specific to uveal melanoma, which is really amazing. The ones highlighted in red, I will actually talk a bit more about in depth, but the ones that are highlighted in purple, I just wanted to just mention briefly. And again, this is really just the immunotherapy trials. And so I will mention the third one down, which was a study of APG-115, which was an MDM2 inhibitor in combination with pembrolizumab. This had a separate uveal melanoma cohort, which again, historically with metastatic melanoma trials, uveal had been excluded. But I think to everyone's surprise in some of the early readouts, and this was presented at ASCO last year, 2022, it seemed actually the uveal melanoma and actually mucosal melanoma cohorts almost looked a bit better than the cutaneous cohorts. So there was a signal in uveal melanoma. It'll be interesting to kind of see where this might go. The last one there that's highlighted in purple, I just wanted to mention, there obviously have been a number of adoptive T-cell therapy trials in metastatic uveal melanoma in the US. A number of them initially were being done at the NCI, where TIL therapy originated. But I wanted to highlight this one because this is a pilot trial of really using specifically LN-144, which is lifely useful, which is the adoptive T-cell therapy or the TIL therapy that will likely be approved for cutaneous melanoma, at least in the US within the next year. So it'll be interesting, once this is approved in cutaneous melanoma, how and why it could be used in uveal melanoma. And so hopefully this pilot trial will very specifically give us information about whether or not it's something we should be pushing for once it gets approval, or whether or not, adoptive T-cell therapy, the way we think about it for cutaneous melanoma, really needs a tweak to be helpful in uveal melanoma, which is my gut feeling. I think it probably will require a little bit of a tweak, especially because it's such a heavy lift, the treatment is. Switching to targeted therapy, again, I'll talk about the trial that's highlighted in red here. I did want to just mention there was another trial looking specifically at metastatic uveal melanoma and other GNAQ, GNA11, so kind of a similar patient group and target. I know this was actually a study that was open in Australia. I think targeting GNAQ, GNA11 is important. It's obviously been a challenge, and even the trial that I'll talk about, the IDEA trial, doesn't directly target GNAQ, GNA11. It's targeting a bit downstream of PKC. So we'll see. This trial is still ongoing, and I think the future is a little bit unknown, but we will see. But again, as you can see in black, a number of other trials looking at different ways to target uveal melanoma more in a targeted therapy kind of way. And then lastly, liver-directed therapy trials, a number of those ongoing. I'll talk about the first two. I think you will hear quite a bit actually about IHP and Ipi-Nivo at some point later today. But there are other trials ongoing combining immunotherapy with liver-directed therapy. And then lastly, you see there's hepatic artery infusion of TIL into patients with melanoma and liver metastasis. So that's really kind of bridging that last bit that I talked about with liver-directed therapy. So lots of different ways we can be tackling this. So to jump in just to a few of the trials that are really showing promise in uveal melanoma, and I think have a bit more clear direction than some of the others, is the first looking at a different type of ImmTAC. So I already told you a bit about Tebentafusp targeting GP100. This is really a similar technology, though instead of targeting GP100, it's targeting something called PRAME. And this is a trial that is ongoing that's actually enrolling a number of tumor types, including cutaneous melanoma, and uveal melanoma, so similar mechanism of action as I've shown before. And what was really remarkable is, this trial enrolled a number of cancer types, including uveal melanoma patients who've not previously had Tebentafusp, and then uveal melanoma patients with prior Tebi. And you can see here, this was presented last year at ESMO, that in those 5 patients who were Tebi naive, 3 had very deep partial responses. I mean, these are PRs that we are not necessarily used to seeing in uveal melanoma. All 3 of which of those patients had prior liver-directed therapy. And here on the bottom, the top's an ovarian cancer patient, but on the bottom is a uveal melanoma patient. And this is a diffusion-weighted sequence on MRI, and you can see lots of white dots on the scan on the left. And the patient cleared their ctDNA, had a confirmed PR, and this really should be updated. And it's been ongoing treatment now well over 2 years. Patient actually just recently had their 100th infusion. So this is, I think, obviously, again, a similar technology to Tebentafusp that's already proven itself in the uveal space, but a different target that is looking very promising. This next trial that is ongoing, I think you will again also hear about later today. This is the drug combination of darovasertib and crizotinib, so darova being the PKC inhibitor, crizotinib being a MET inhibitor that is improved at least in lung cancer. And there's been a lot of work done preclinically to kind of explore possible combinations with darovasertib. It was initially tested as a single agent, and then MET was found to be a good partner. And so the trial has been ongoing for quite a while. And here you can just see some waterfall plots. And this is really any line metastatic uveal melanoma and hepatic only metastatic uveal melanoma. And these are patients, again, who are first line or pre-treated. Again, I think the first time a lot of us saw these waterfall plots, these were not necessarily waterfall plots that we are used to seeing in uveal melanoma with very deep PRs and the majority of patients being on the, underside of the line. The confirmed overall response rates are in the 30s. Greater than 30% tumor shrinkage, not necessarily confirmed, is in the 40s. Disease control rate for all comers, 87%. And in this small cohort of patients with hepatic only, a disease control rate of 100%. This obviously is a new bar, if you will, in metastatic uveal melanoma. We had not seen numbers like this in systemic trials, certainly not targeted therapy trials. I used to have a slide up here with the whole MAP kinase pathway and all of the trials that have tried to combine a little of this, combine a little of that, and their kind of response rates really being anywhere from like 0 to 3%. And so this certainly has taken things to the next level. And so here are just some examples of some patient scans who've had shrinkage, and durable response, patient being on treatment for 15 months, and the patient on the right as well. So what this has resulted in, as you can imagine, is a proposal for a randomized trial, which is being developed, as well as a neoadjuvant trial, followed by adjuvant therapy. It's some of this work coming from what's been done and some observations in Australia by Professor Joshua and team. So this is very exciting. Like I said, I think you're going to hear more about this drug combination later today, but this is certainly something that is very close to opening, and data should be on the horizon. Kind of pivoting, so we talked a bit immunotherapy, I talked a bit targeted therapy. So this is a newer liver-directed approach. This is PHP, standing for percutaneous hepatic perfusion, that really requires a a catheter system that really blocks the circulation outside of the liver and allows you to perfuse the liver with high doses of melphalan, and then being able to kind of collect the blood and then filter it outside the liver. So the trial initially was a 1-to-1 randomized trial of PHP versus best alternative care, investigator's choice really of TACE or immunotherapy or chemotherapy. And then the trial, after a bit of time, went to a single arm trial. You can see there the treatment course of PHP. And even though the trial has finished, there is an expanded access program ongoing at various centers. This is just a brief snapshot of what's been presented as the endpoints for this trial. So you can see, again, more patients receiving PHP because it ultimately went to a single arm. And overall response rates and disease control rates here, and OS of 75% 1 year versus best alternative care. So again, something else that has shown some promise and will likely, hopefully, be an option for our patients in the future. Then I will switch to a couple of combination strategies that have been developed that have been in trial. The first one being PERIO-1, which is hepatic artery infusion of SD-101, which is a TLR9 agonist. For those of you who might treat cutaneous melanoma, you may be familiar with these TLR9 agonists being intralesional therapy. But this trial will take that and then using a special device, pressure-enabled drug delivery device. So it's a special type of catheter that really improves flow and overcomes intratumoral pressure to try to get drug to its destination. And so the thought is between using the PED and using the TLR9 agonist, which the mechanism here is thought to potentially decrease myeloid-derived suppressor cells in the tumor microenvironment, that this approach could enhance response to immune checkpoint in MUM. So there is a trial ongoing of single agent, then combining with nivolumab, combining with ipilimumab, and then combining with the combination. And so I know this is very, very tiny, but just this was an abstract that was presented, actually had an oral at ASCO just a few weeks ago, so you can find that. But basically just showing that we've enrolled to all of the cohorts. In general, it's fairly well tolerated. What we're really seeing is a side effect profile of the immune checkpoint inhibitors. There doesn't necessarily seem to be much in the way of added because of the liver infusion. And then on the right, again, I'm sorry, it's very tiny, but yeah, there's the swimmer's plot. A number of patients have remained on treatment for quite a while. And then here again, also very, very tiny, but you could certainly find and look at the poster. But really what we're seeing on the left is, one of the amazing things about this trial is there have been so much science, so much correlatives, lots of biopsies taken, blood draws taken to really better understand what's happening in the tumor microenvironment and in the peripheral immune system. So, what we found is that everything's really going in the right direction. So, there's a broad immune effects in the tumor and the tissue in the periphery. We see depletion of myeloid-derived suppressor cells, which was the initial kind of hypothesis with using the TLR9, and then reduction in myeloid-derived suppressor-associated genes. And then on the right-hand side, we've also been looking at circulating tumor DNA because we did learn from the trials of Tebentafusp that sometimes ctDNA actually better correlates with survival than does true radiographic RECIST. And so we're also collecting that and have shown 61% of patients who are measurable at baseline showed a favorable decrease. And so we will continue to collect this information as well. And so these trials are ongoing. And then the last combination treatment or strategy approach trial that I wanted to mention is RP2 plus immune checkpoint. This is an engineered herpes virus and GM-CSF, so similar to what you may recall for talimogene laperpivac or TVAC, but added Gal-VGPR and CTLA-4. This was specifically, again, a cohort of uveal melanoma patients. Lots of patients who actually previously received and failed checkpoint, including combination ipi-nivo, who then went on to actually have a partial response after treatment with this combination. So with a disease control rate of 57%. And then just a few examples, actually one of these patients had injection into a recurrence kind of in and around the orbit, as well as bone mets response, and then also liver response. So I know that was a lot, but I think it's just very exciting that there have been such great strides in the field of uveal melanoma, really just over, the last, 5 to 10 years. Certainly the approval of Tebentafusp has paved the way for other novel therapeutics to be tested in really a rare cancer. I mean, the fact that Tebentafusp was a successful global randomized trial that was able to accrue to a, not even the whole population, to an HLA restricted population, and we got it over the finish line is really quite remarkable. Approaches right now that are exciting are spanning the landscape of immunotherapy, targeted therapy, local regional treatments, as well as combinations. And I think, we're starting to find ourselves where lots of other cancers have for a long time, that with the increased number of options, we're asking ourselves, who, what, when, how. And I really hope we're also trying to ask ourselves and answer why, because I think we all get very excited when we see, great response or, great response rates and scans that show shrinkage. But I think it's really understanding the why that's going to help us, because, again, it's not, uveal melanoma is rare and there's only so many patients, and we want to do what's right, and not be picking treatments, for the wrong populations. And so, now more than ever, uveal melanoma patients require a multidisciplinary team with unique expertise, just to make sure patients are getting the best treatments as early on in their disease course as possible. And the fact that this is soon to include neoadjuvant and adjuvant approaches, I know there's a lot of ocular oncologists and ophthalmologists, I think, listening in. I mean, this is a partnership that needs to happen from day one, if not even before day one, to make this seamless for our patients. And then lastly, I think the fact that we have such a collaborative international community, we couldn't do this, without everyone's support. So again, I just want to thank the organizers for having me, and it looks like it's going to be a great day of talks. So thank you.
Marlana, thank you so much. That was just a wonderful overview of where things are and where things are heading. So I thank you very much. And it does sort of lend to that collaborative approach, you coming and speaking to us today. Professor Mark Shackleton's got a question for you, if we may. He's wondering what criteria you used to decide to discontinue Tebentafusp. You had a lot of patients continuing on treatment, but what criteria would you use?
So, I think for those of us who are used to and familiar with using immune checkpoint inhibitors, it's nearly not that much different from I think the kind of rule of thumb there. And that, certainly at time of first scans, if you see a little bit of growth, so what's a little bit, 20%, maybe one tumor grew a few millimeters, one maybe, certainly if you have a mixed response, grew a little less, or if you had a really large tumor that was growing very quickly, and even if another new little tumor shows up, we tend to give patients the benefit of the doubt and repeat scans. And sometimes that's repeating scans in just 4 weeks, or that's stretching it out a little bit further. My rule of thumb now is I always kind of ask myself, if I see a patient who's progressing and I'm not certain, is this, I don't like the word pseudo progression. I mean, I think in many ways it's normally actual progression. It may just be the fluctuations of what's happening with the tumor. There may or may not be immune cells surrounding it, but I ask myself, if I keep this patient on this therapy and I repeat scan, will we be in trouble if the kinetics stay the way they are? And if I don't feel comfortable with the tumors growing in the same speed that they just grew, then I may change treatment. like I said, you know, certainly if the patients are having new symptoms and their labs are worsening, you know, then you want to consider taking them off. But like I said, one of the other things that we've been doing is if I have a patient whose scans look great, but maybe there's just one tumor that's misbehaving, especially because they're getting treated now as standard of care and not necessarily on a trial, you know, we'll ablate it, we'll radiate it. Sometimes we'll remove it if we really think patients otherwise getting clinical benefit.
And for patients who've had that long benefit, and you think their disease is stabilized, would you stop the treatment or would you keep it going if they're tolerating it?
Were we talking about Tebentafusp here?
Yeah, yep, Tebentafusp here.
I have not stopped.
Okay.
Yeah,
Yep,
I mean,
okay.
patients, I feel a little bit more comfortable patients, you know, missing a week here or there, because obviously weekly treatments for these patients is a big commitment. You know, our
yeah.
one patient who's since moved has been, you know, on it for 80 months or what, you know, I can't say that it's been religious, you know, the weekly treatments, but not stopped anyone officially.
Look, thank you for that. It would be lovely to continue to ask you lots and lots of questions, but we'll need to move on now. But thank you once again for a wonderful talk.
Thank you.